Good evening, everyone. First of all, just myself and George Urology want to thank you for taking time out of your evening to learn a little bit about men's health. As Kelly said, this is anonymous. We don't see names and those kind of things. Questions are freely welcomed. And as I like to say, no question is off the table. This guys is for you and couples alike. So please get the most out of this as you see fit. With that, again, I appreciate everyone coming on, and we'll get started. So first of all, just a little basics, I think kind of ED 101. And typically these talks I start with erectile dysfunction, but understand we're going to cover a bunch of topics in here. And a lot of this has to do with what I like to term prostate cancer restoration. A lot of men who go through prostate cancer treatment suffer with some things that they think there may not be options for. I want to undo that myth tonight. Basically, I don't think we need to kind of go to what is it? But again, basically, it's the inability to maintain the erection through sexual intimacy. It does affect about 1 in 5 men in America. One of the things that I hear common is I'm the only guy that has this. I have a saying, if you get in an elevator, you're over the age of 50, one of you have it. So a little pat on your back that you've kind of come out tonight and learn about things, because a lot of men suffer in silence, and we want to be able to help so that you don't have to. Again, about 39 million men have this condition. So again, the penis actually fills with blood. That's how you get the erection. So it is a blood flow issue. And that's why we want to look at, some other causes that we can think about your men's health when it comes to your erections. We do need the veins to kind of compress. So the pressure builds up in the penis, which compresses the vein that allows the blood to stay in the penis for the erection. There is something called venous leak, and that's where the veins themselves don't compress. And that also is something that we can address, sometimes addressed differently than the more common things like the pills that most men know about. This is a really, really important slide that I've spent a little time on. As I said, we call this prostate cancer restoration is one of my passions. But you see in this slide, only 6% of men have had pelvic surgery who end up with erectile dysfunction. The 3 most common things are all related: vascular disease, diabetes, and medications. And again, these go hand in hand. So 85% of the time, the erectile dysfunction is vascular in nature and has something to do with an etiology or medication addressing those issues. So this is where a lot of my passion comes from. Again, if I say to couples that, or other doctors out there, with a 93% certainty, I can predict who's going to have a heart attack or heart issue, most of my colleagues outside of urology or cardiology don't believe me, but it's absolutely true. About 93% of the time, men who have cardiovascular disease, now that's heart disease, arrhythmias, chest pain, shortness of breath, associated with heart failure, heart attack, all present with ED first. So it is a silent indicator of coronary artery disease. In fact, it's actually an independent risk factor. A lot of people know that family history is a big risk factor for cardiovascular disease in men. In fact, actually, erectile dysfunction is a more better predictor of heart than family history. So again, this is where I tell men to, if you have this issue, you're on this seminar and you're learning about it, when you're in those social settings, and this comes up with people or ladies a lot of times talk more than we do, use this, because you actually can drastically change somebody's life by just mentioning the fact there's a high correlation between ED and heart disease, and they may have heart disease and not know it. And I've actually seen this personally in my practice, where we've actually used ED to screen people and actually get them intervention before their heart attack, which was pending. Again, this slide talks about 93% or 70% of the time. Some studies talk about up to 93% of the time. And then here you look at the lead time. We always talk about a lead time, how long before this occurs. About 2 to 3 years and up to 5 before you get some of the more major events, such as a heart attack. So there is a lead time, and you need to pay attention to this. So take-home message from this slide and this talk, if you get one thing out of this talk, is if you have ED, please get cardiac screening. So if you don't have a cardiologist or get an annual physical, please go do that. And here's why. And this is a picture that basically shows the vascular flow. As you see, the penile artery is about 2 millimeters. The one in your heart's 4 millimeters. So it makes common sense and common logic that you're going to get the problems in the penis with the erection first. So again, pay attention to this from an overall health. Again, my treatment for ED, erectile dysfunction in men's health, has nothing to do with the sexual intimacy. It has to do with their overall health. Remember, as I like to say, I'm a doctor first and a urologist second. So again, what are some things that you can reduce your risk? All the things that you hear about, they're the hard ones though. The hard things we as physicians ask patients to do is change their lifestyle. So again, when you talk about diet, exercise, weight loss, quitting smoking, again, if you smoke, you're 3 times more likely to lose your erection than the average man. So put that in context. If 50% of men age 50 have ED, if you smoke, you're now tripled that risk. So the numbers don't play in your favor. Physical exercise. So what does physical exercise do? Well, with any physical exercise, we're dilating vessels. The vessels are just muscles. And if we're not exercising those muscles and increasing our heart rate, then the artery itself is not getting its quote exercise to expand and bring the blood to the penis. There is a little bit of concept of use it or lose it here. So that's why we're relatively proactive. You're going to hear a little bit about that in the future, about how to be proactive to prevent this problem or to treat it in such a way to make outcomes better. Erectile dysfunction and low testosterone. Again, men's health is an interest. Low T also increases your risk for heart disease. We've already talked about erectile dysfunction increasing your heart disease. So those men who have erectile dysfunction should have a testosterone. I typically recommend a testosterone baseline around the age of 40 so that you know where you're at in your 40s. Now, if it's low, we treat it. But if what happens, people come to us when they're 70 or 65 or whatever, and we don't know what their normal testosterone was, and that can affect how we want to treat the patients. Also, it is a little bit of a misnomer. So people that have low testosterone, most of the people who have low T, fixing the testosterone will not fix the erections. It will increase your desire for intimacy, your energy, protect your heart, all those things that testosterone does for men, but it will not fix the ED. Now, if you're a young guy, let's say early 40s or whatever, then a lot of times fixing the testosterone will. But if you're the average patient, let's say in their 60s, 70, replacing testosterone will not affect that. So again, it's very prevalent. As you see here, about 4 out of 10 men have it. Percentages rise as you get older. And again, we see low testosterone in very other in situations such as diabetes, high cholesterol. So again, having a low testosterone in a diabetic, in fact, actually makes it harder to control the sugar. So again, we want to get your testosterone checked. So what are the lifestyle choices? I'm not going to spend a lot of time. I think most of us know what testosterone does to us. I call it the 4 o'clock nap syndrome. People that come to me and say every day at 3:30, 4 o'clock, I am just wiped out, I need a nap. Very high sensitivity for having low T. Obviously muscle loss, not being able to recover from workouts and things. There's a common thing we hear. Replacing testosterone can be through testosterone gels. Sometimes we call those patches. They come in a patch form instead of a gel you have to rub on your body. There are some oral medications. Most of those are used in men who want to maintain their fertility. Obviously, testosterone injections, and those come in the method of either a short-term injection, or there are some long-term injections that last 10 weeks, so you're not having to do injections every 1 to 2 weeks. Again, I hope I'm not going too fast. I didn't give that disclaimer. I do enjoy the questions, so I do move through the slides pretty quickly, as I really want people to be able to have time to get their questions answered. As we mentioned, erectile dysfunction and prostate cancer is prevalent. This is probably the #1 reason men choose not to treat their prostate cancer. And when I go through a patient with prostate cancer, the first thing that I tell them with a new diagnosis is prostate cancer will almost guaranteed not take your life, will not take your erections, and will not take your continence unless you let it. That's what this talk and about prostate cancer restoration is about. So if you've had prostate cancer, you have friends that are newly diagnosed, you're diagnosed with prostate cancer, understand that the treatment of the prostate cancer will not affect your erections long-term unless you let it. It may in the short term, and there are things that we're going to talk about to fix that. So why does it occur? Again, here's a depiction of, on the top right-hand corner, the bladder, the prostate, and the sphincter. These nerves are, we call the neurovascular bundle, and these are the ones that provide erectile function. You can see in the bottom where the prostate's removed, they're saving the nerve. Most of us high-volume surgeons for prostate cancer are going to save the nerves on both sides. And hopefully most men, about 70% who come into that surgery with erectile function being normally, will come out of that surgery ultimately with their erections intact. So again, another misnomer. In fact, actually in Alabama was the second highest death rate for African Americans for prostate cancer. And the number one reason those men gave for why they did not treat their prostate cancer was the fear that prostate cancer would absolutely take away their erections. So we want to undo that misnomer. So again, overall erectile function rates do vary. If you read studies, about 25 to 75% of the men who undergo the treatment will have that. But I'm going to circle here on the 75 range because, again, this varies on men who are surgeons who are high volume surgeons. So again, I am a volume matters kind of guy. So again, if you do something more frequently, you're typically going to do it a little bit better. Not that any surgeon's better than another. It's just the frequency of the operation. So most of us who do a lot of prostate cancer surgeries, or even, for example, in a minute, we'll talk about penile implants, are going to have outcomes which are favorable to men. And that's where you get most people in about the 60 to 75% chance of having erections after. The sexual dysfunction will occur up front with surgery. Now, I didn't mention radiation. That's the second most common reason or method to treat prostate cancer. And that has an erectile function of about 50%. In other words, if you choose surgery or radiation, your erectile function and continence rates are going to end up in the same place. There's just a different method to get there. In other words, surgery, you have the problem, it gets better. Radiation, you don't get the problem and it gets worse. So again, the two modalities to treat prostate cancer are surgery and radiation. The erectile function outcome rate at 5 years is essentially the same. But whether you start with surgery or radiation, it's absolutely a fixable issue. And I will stop and say again, you can do some things to help that. Talk a little bit about vacuum erection devices in a minute. By using a vacuum erection device, any man who's having erectile dysfunction, by using a vacuum erection device on a daily basis, and that's what I have all my prostate cancer patients, whether surgery or radiation, do, that's going to prevent curvature. It's actually going to regain a little bit of your length and prevent any kind of scarring. So again, vacuum erection devices can be used in a rehabilitation method, not only as a function method, which we'll talk about in a second. But what is Peyronie's disease? A lot of people know what Peyronie's disease is by name, but most people call it just curvature of the penis or penile shaft with erection. There's a high concordance or these two processes occurring together. What happens is you have a scar someplace on the actual penis. That scar typically occurs through some mild sexual trauma that most people don't remember. There are instances where you get what's called a penile fracture. That's where the penis itself buckles. Blood will leak out of where the rupture is, and that will then cause the scar. And you see in this picture, there's a plaque, a fibrous plaque or scar on the top part of the penis. The scar itself does not expand, so that causes the underneath side to expand more disproportionately, which causes the curvature. We don't typically treat the curvature when it's mild. If it interrupts the ability to have an erection, ability to have intercourse, either insertion from rigidity or curvature, if it's painful for patient or partner, or some unusual stress about it, then those are instances where we're going to offer options to intervene. And there are very good options for those, whether you have ED with Peyronie's or ED in of it, or excuse me, Peyronie's in and of itself. Again, the Peyronie's also, again, is something where if you want to fix that, ultimately using a vacuum erection device helps soften that plaque and regain some of the length and girth that may have been lost, not only in a preventive measure, but also in a treatment for the erectile function or the curvature in and of itself. So what are some of the options for erectile dysfunction in men? I think everybody knows about the oral medications, Viagra, Levitra, Cialis, Stendra. The most common question I get is, Doc, which one's the best? I call them Sprite, Pepsi, Coke, Mountain Dew, Mellow Yellow. In other words, there are no superior studies in these. They're all equivalent in their efficacy. I do recommend that most men try 2 medicines at least. If Viagra doesn't work, another one might. If Levitra doesn't work, then Viagra might. So again, not that we're specific. Most of these medications now are generic, so cost is a little bit more affordable. They do have some really good rates in the beginning. You have a lot of men who graduate out of oral medications. It used to work and it doesn't work anymore. That just because the medication does not work does not mean that we as a couple need to stop being intimate. So there's always option. And there are some people that, again, medications may work, but they have significant side effects. They can cause headache, they can cause back pain, and these medications are not benign, and sometimes the side effects are not worth taking of the medication, and men want to go to other options. Again, the bottom just draw it here, diabetes. We talked about smoking, increasing your risk for erectile dysfunction. Diabetes makes you about 2 to 3 times more likely also. So again, and your failure rate or oral medication is slightly higher in diabetics because of the diabetes and what it does to the medication. Excuse me, what it does to the erectile dysfunction. We've covered most of this slides. So vacuum erection device. I do like to spend a little bit on this, as I said, because we're going to use this for rehabilitation. We're going to use it pre-op if that's what people choose. But we're also going to use it for function. So basically, this is just a device that goes over the outside of the penis. You put the device on. I typically recommend a battery-operated medical grade device. They tend to work better and more reliable. Almost every man can get one of these to seal. The most common thing is I can't get it to seal. There are some ways that we teach you how to do that. And if you get it to seal, it will get the penis erect. As you see in the picture, the band goes around the base of the penis to keep the erection. So again, if you want to use this device for intimacy, you would use that with the band on it. However, any man who has erectile dysfunction, I recommend getting one of these devices, using it on as much of a daily basis as you can, where I tell my guys to do 4 erections. You will sit down, you will use the device, you will get 1 erection, 2 erection, 3, and 4 right in a row. But one of the erections, you're going to allow that device to sit there and the vacuum device to stay on to stretch the penis. That's what's going to allow some of the fibrosis that occurs because you don't have erections as often as you did, or it's been a period of time where you've been intimate, to help make that tissue more pliable, so that when we do return the erections, or if you do end up with a surgical option, it'll be better. But more importantly, it helps regain some of the length and the girth that may have been lost because you've not been intimate with that. Again, like I said, I have every one of my patients doing prostate surgery to start using this at the beginning so that we don't get those. Satisfaction rates are pretty good initially. I think this is a number that's a little high. You have a high dropout rate with the vacuum erection device. People just don't like using it. It is a little cumbersome to use, and they don't mind using it temporarily. So again, some bruising. Diabetics also are not a big fan of this because, again, it can cause some numbness and coldness to the penis and decrease the sensitivity with the actual intimacy. Muse is a little capsule that goes down into the tip of the penis. I'm going to group this one along with injections. Injection and Muse, or the little capsule that goes in the tip of the penis, okay, are the same medication. They work the same method by dilating and stretching the artery to allow the blood flow to come in. However, most men, in my opinion, tend to prefer the injections. And the first thing I get with every man that I discuss is, you want me to inject what, where, how? No way, no how. And I will say, don't knock anything till you try it. It's very effective. It works very quickly. So your onset can be 5 to 20 minutes. Over 90% of men who are taught how to do penile injections are willing to do it again. About 60% will continue the use. And then again, you do have a dropout rate. So you're going to have men who either over time fail the injections, either they don't work anymore, or they just say, look, we really like the fact that we're able to be intimate as a couple again with injections, but we want it to be more natural. We don't want to have to do this. And again, I find that especially if you end up seeing a urologist like myself, which concentrates on prosthetics, that the people will say, look, okay, I'm getting my erections and we like this, but we would like to be more natural, and we'll go to a permanent fixed. You can get some fibrosis and scarring. So where you do the injection, we're going to teach you how to move that site around so that you don't get that. But again, this is a very effective way to return the erections quickly. So that, again, it's one of the ways that those of us who do a lot of it can prove to patients that we can fix this. Because the most common thing we hear is, hey, I've been to several urologists and I've tried 3 drugs and it doesn't work, and we've just given up on that. So finally, let's talk about a more definitive treatment for erectile dysfunction, and that's something called a penile implant. Now, the first thing that I want to say is you should think of a penile implant no differently than you do a knee or a hip replacement. So in other words, if you were to get arthritis or have an accident and needed a knee replaced so that you could run, jump, jog, play tennis, whatever it is you enjoy with your quality of life, you should think of a penile implant no different. In fact, actually the satisfaction rates of a penile implant and the infection are higher and the infection rates are less. So if you look at people who have penile implants, you have a satisfaction rate of about 92 to 98%, just depending on which paper you're going to read. So very, very high satisfaction rates. And partners. A lot of people say, well, what about my partner? Over 90% of partners, men who have a penile implant, would recommend their husband, spouse to doing it again. So again, these are very, very satisfying. Real quickly, no one will ever know it's there. A lot of people say, well, gosh, I don't want to do that. I don't want to tell my family. I don't want anybody to know it's there. No one ever knows this device is there other than the patient and their partner. And everything is really natural with this. Both couples will say it just works, and it's reliable, and it just feels the same as it always did. So I'm going to look through. Here's a little demonstration that we're going to watch. This is a man who has a device in place. And what you're going to see is he's going to reach between the actual, in the scrotum, between the testicles, where the little device sits. And he's going to pump that device several times. And as he pumps the device, fluid is transferred from a reservoir in this device. There are several. And the penis becomes erect. So again, very quick onset of being able to get the erection. So spontaneity's return, reliability's return. And here you see the man deflating it. So he presses the button in a different area and the penis becomes flaccid or soft again. And that's how it works. Again, these are very satisfying. Again, it's just there, it's reliable, it's ready whenever the couple is ready. And one of the advantages that all of us who do a lot of these, again, will tell you, though, the most common things we hear from patients of why would I do an implant again, or what do I like most about it is, as you saw in the video, the device, once inflated, was inflated and stays hard until he chooses, or the couple chooses, to deflate the device. So that is one of the most commonly touted advantages of this device. Penile implant is a permanent choice. So it does, again, return the spontaneity. We talked about it lasting as long as you desire. Again, you say, well, gosh, nobody has. That's very rare. As you see at the bottom, 500,000 of these been put in place. And I would probably say that's a relatively conservative number. If you look at, there are two companies that make these devices. I don't know that that includes both of them, but again, so I think it is a very common procedure, a lot more common than most people think. Again, another thing we hear as prosthetic urologists is, hey, I played golf with Johnny for 10 years, and finally after 5 years, he told me I had an implant, and now I want to come see you. I usually say one of my biggest referral for people for ED, especially when it comes to penile prosthesis, is patients who have them in place. And it is also very interesting and fun or funny for me to see a patient who comes in, who goes through the evaluation and walks through the steps of erectile dysfunction and ends up with an implant. The first thing he's going to say is, I am never, ever, ever telling anything about this. In fact, my biggest referral is that patient. So again, very, very high patient satisfaction. Real quickly to touch on the surgery itself, it's about an hour-long procedure. Some as short as 20 minutes, just depending on anatomy and which device. Again, we showed here a 3-piece device. So that device had 3 components. You saw the part in the penis. You saw the part that he actually manipulated in the scrotum, where he actually pumped it. And then the reservoir was where the fluid was transferred from. There is a 2-piece device. And there's also a malleable device, which is always kind of firm. It's kind of a semi-rigid rod. And those are really good for people that have dexterity issues or severe arthritis. I've put many of them in men who've had a stroke and cannot operate, let's say, a hand. So there's good options for everybody. Recovery time, typically I tell you about a week, give or take a little bit. The 2-piece device is a little bit less recovery, a little bit easier to learn how to use. The 3-piece device has the advantage of being a little bit more natural. It's a little softer when it's soft. So a lot of men like that device. And you can actually go to the website edcure.org. That's edcure.org. It's not .com. And actually look extensively about these 3 devices and the variations in them. Insurance, most all of these are covered through insurance, definitely covered through Medicare. If you have Medicare and a supplemental, I can almost guarantee this will be the cheapest way and the most reliable and effective way to treat your erectile dysfunction. We always approve that through the insurance prior to doing it. So that's something that we do. And the company also has an appellate process if we need help to rely on. Again, mainly the risk is just the discomfort to go through it. There's a very few that will get infected. Actually, the AMS device is coated with an antibiotic solution on the actual device itself that helps prevent the infection. And it's actually the only device that is indicated when a man who would have an implant who's actually infected to be reimplanted on. So again, a very uncommon situation, but definitely a good solution. Here's again the website edcure.org. And I love there, it says talk to your partner. I call that a marriage discussion. So I highly recommend those and get on the same page. So I'm going to switch gears real quickly. I see a lot of questions. That's wonderful. So try to run through this to get through that. Urinary incontinence. I want to touch on that. A lot of what I'm going to talk actually talks and applies to women too. So you can, if you're a lady on here, we've got something for you too. A lot of what we talk about for male slings can apply to females. So again, urinary incontinence is just a leakage of urine with activity, is what we call stress incontinence. So you cough, sneeze. Most commonly in men, we see stress urinary incontinence after some type of prostate surgery. That can be cancer surgery, that can be radiation, that can be a TURP. But it does occur in men who have colon cancer, which also occurs in men. Erectile dysfunction occurs in men who have colon cancer surgery. So this is not just a prostate cancer issue. And again, about 9 to 16% will have some persistent urinary incontinence. I think, again, this is a little bit high in men who are urologists who do a lot of prostate cancer surgery. We looked at our data about 3 years ago, it was about 3 to 4%. So again, make sure you get somebody who's doing a lot of the surgery that you desire, and that's across the board, whether it's knees, hips, penile implants, TURPs, whatever it may be. Again, the bladder needs to store the urine. The sphincter, as you see here, needs to close off to keep it. That's where the defect is when you have the stress incontinence. You can see stress urinary incontinence in neurological diseases. Just a simple enlarged prostate where the bladder is having to do too much work, that actually is typically what we call urge incontinence. The patient gets an urge and they cannot get to the bathroom quick enough. Slings are not usually indicated in that situation, but can on rare situations be used. We talked about radiation. Radiation does cause urinary incontinence. I'm a little biased here. I think this number is on the lower end. I think it comes out of the radiation oncology literature, which sometimes they don't always see patients long-term. But still, it's not excessively higher. It's about the same as with surgery. But men can get weakness of that muscle from radiation. Urinary incontinence has significant negative impacts on your quality of life. And again, I think all of us probably on here would agree, quality of life is much better than quantity of life. And we want to make sure that we have that quality of life. Again, depression rates in stress, or men who have stress urinary incontinence, also men who have erectile dysfunction is higher. They limit their activity. They're socially not as active. So again, it's something that we definitely want to work on. Again, we talked again about this and where the nerves are, et cetera, with this, and you can injure the sphincter, which you see is very close to where the prostate was actually removed. Again, most men after a prostate cancer surgery will get some urinary incontinence initially. It gets better. I have a rehab program, so we have you go see a physical therapist just like you would if you had a knee or a hip. We're going to put you in pelvic floor rehab. If you choose to have prostate cancer surgery here with Georgia Urology, and that will help reduce your risk of those being long-term. Almost all patients are able to regain their continence, but not everybody. So what are some of the options? Again, you definitely want to see somebody who does a significant number of these. So we look at behavioral modifications. That's just, again, making sure that you're limiting your fluid intake or you're going to the bathroom on planned breaks. But mainly the big thing here is pelvic floor therapy or pelvic floor exercise. Now, most ladies know about Kegel exercises. Us men don't do them very well, don't understand them. So we do need some help. That's where we're going to see a physical therapist. Biofeedback is where you're using a computer and a program and a monitoring muscle contraction to make sure you're doing the exercises correctly. Highly beneficial, probably increases efficacy at least 30%, maybe even more with that. And then coping mechanisms. And I want to touch on that because pads have a significant amount of cost. Very frequently here, both men and women come in and talk about the number of pads they're using and the financial ramifications of that. And here's just one that looks at, a person who has 5 pads a day, 5 years, $7,000 is what they're estimating with this. So it's not insignificant. If you look at that into a procedure which reduces that is covered by insurance, it's much more cost effective to treat the ED or the stress urinary incontinence in this situation over the long term of the patient. So there are 2 things I want to discuss real quickly on urinary incontinence, and that is a male sling and an artificial urinary sphincter. So a male sling is a support mechanism that is placed up underneath the perineum where the prostate to reposition and add a little bit of compression so that you can maintain your continence. They're highly effective, more than about 85% effective. Usually we're going to do the male sling in those patients who have kind of mild to moderate leakage. We usually talk about less than 4 pads a day. Sometimes we'll go a little bit higher, but again, that 1, 3, 4 pads a day leakage is an excellent option. It offers instantaneous continence, so you leave the operating room dry. That's one of its biggest advantages. It is a small piece of mesh. Understand that a lot of people, when we say mesh, they get a little nervous for all the publicity that's been out the past few years. And I respond to that to saying, realize that every hospital, every single day in every U.S. city uses mesh. All hernia repairs are done with mesh. It's basically who's putting the mesh in, where are they putting it, and how much they're putting it. The vaginal mesh, a lot of people worry about, had some issues and kind of got a bad name for mesh in and of itself. But mesh is not the problem. This is put up underneath the urethra to provide support. There's very rare incidences of erosion or complications from the mesh in men. Again, like I said, this is about an hour, 45-minute to an hour procedure. You get to go home the same day. I didn't mention that also on the penile implant. You get to go home the same day. It's outpatient surgery. Same thing with an artificial urinary sphincter. We call this an AUS. This is a device that replicates the normal sphincter that wraps around the urethra to provide control. And I think there's a video. This is the one on the male sling. So real quickly back, I think we covered most of this. Normal activities relatively quick. I'm going to stretch this out in my patients because, again, I want the sling to set in place and become affixed where it should be. It does restore that normalcy and confidence. The male sphincter, again, it does mimic your natural sphincter. There is a little device in the scrotum, just much like the penile implant, that the man would push. As they push that, the sphincter opens, allows the urine to flow out, and then over 60 to 90 seconds, that device will close back up to provide the continence for the man. And again, I think here's, again, a demonstration of the artificial urinary sphincter and how it works. Again, you'll see a small device, much like the penile implant, in the scrotum that the man would operate to be able to maintain continence. As you see here, it's wrapped around the urethra. It's closed so that urine doesn't leak out. As the man pumps the device opens, the artificial sphincter opens, urine flowed out, and then over the next 60 to 90 seconds, it closes back up to provide the continence for the patient. Again, I like to say live life dry. Leakage is a choice. You don't have to have urine incontinence. If you do suffer with this, there are urologists who have a special interest in this, like myself and some of us here at Georgia Urology. And again, website for this one is fixincontinence.com. It's a great website, has lots of information that we've gone over tonight and a lot more detail, also with the animated views that you can see. Again, both of these are also covered by insurance. Risk or minimal. Infection being the biggest thing that we get concerned over, which is about 1%. Again, it's no different than you would have almost any other surgery. And postoperative pain is pretty low, and also covered by insurance. We talked about that. We work with your insurance company to make sure that is approved prior to the actual procedure. Again, I think it's just, as I like to say, arm yourself with information. You're doing that tonight and continue that. You get choices and know the options available to you, and you don't have to accept those conditions. As I also like to say, we're all getting older, but we don't have to go quietly into the night. We can kick and scream a little bit, and this is one of those options where things are taken away from us that they don't have to be, and there are plenty of options to fix that. Again, our website with Georgia Urology is gaurology.com. There's also information there. Go under my name as a provider. I have several radio shows that I do. You can listen to those about urinary incontinence or erectile dysfunction to provide more information or to review some of the things that we've discussed tonight. And with that, I am going to open it up for questions. Again, I want to say that I do these out of joy, and what I enjoy most about these are your questions. Again, you've spent the time to come here, ask your questions, get them answered, because again, you cannot make a decision, especially a medical decision, without proper information. So with that, Kelly, I'll let you
take Thank you, Dr. Sharpe. And I just want to say there are so many questions. So thank you all for your engagement on this. And Dr. Sharpe, if you want to go back to your title slide, just so we're not looking at all these references. But I just want to say thank you, everyone, for your questions. And I'm trying to keep up with this, and we'll try to answer as many as we can this evening. So Dr. Sharpe, if you're ready, I'll go ahead and get started on these questions. This patient says, I have a penile implant. Am I still a candidate for a sling?
Yes. If you have the device in place, we always like to do those together. So you hear us talk about these together as prostatic urologists and men who've got prostate cancer. We want to try to, if you have incontinence and erectile dysfunction, we want to address them at the same time. But sometimes they don't occur at the same time. There are situations where insurance don't let us. So you can go back and do these procedures, and actually having the implant device in place actually helps a little bit with the sling and identifying where some of the landmarks and structures are that we need. So absolutely, you can do them, and vice versa. A lot of men who have urinary incontinence, they get so focused on that's their biggest quality of life, they end up fixing that, and they look, I don't worry about intimacy. I'm wet. I'm wearing 5 diapers a night, and we don't want to do that. And then they're dry, and like I said, depression's less, activity's better. Then come back and say, hey, how do we now fix the ED? So absolutely an option to fix either a sling or a sphincter after a penile implant.
Okay, great. Thank you. The next one is the penile implant surgery an outpatient procedure?
Yes, all the procedures I discussed, they are outpatient procedures. Independently of themselves, they're about 45 minutes to an hour, like I said, give or take 20 minutes. If you add them together, so you're doing a penile implant and then a sling or an artificial sphincter, you're looking at somewhere around 2 hours. But both of those are all those are outpatient. So a lot of people like that. Again, I don't want to do them in the hospital because I don't want people in the hospital with other people who are sick and have infections. I want you at home. We will control the pain, but absolutely we do as an outpatient. And a lot of people like that too because it's a little bit less, more discreet. So come in, have the procedure, go home. And a lot of people are on that topic. We're about, what am I going to tell my friends, my family, my daughter, son, whatever. We have plenty of ways around that those of us who do a lot of these to guide you through that if that is one of your reservations. And that will discreetly be able to do this without any problems.
Okay, and then the next question, this patient says, I'm 78 and had no success with quad mix. I'm in good health. Does my age disqualify me from a penile implant?
First of all, thank you for asking that question. I forgot to mention that. Absolutely not. Last year, I did 3 people over the age of 83. The oldest man I've ever done was 88. So again, sexual intimacy doesn't stop with age. Some people stop at 50 and some people want to continue at 90. So again, your age tonight is your medical health. What I like to look at is what's your medical health. I have some 78-year-olds who are healthier than I am. And I have some 65-year-olds who are not healthy as my 80-year-old. So no, age does not play a factor at all in my decision-making and those of us who do a lot of them. And as I've mentioned, the 2 different devices, I tend to really, really like the 2-piece device in the older patients because, again, that's a procedure they've probably done in 20, 25 minutes. It has only about a 3-day recovery time, and it's much easier to kind of learn and ultimately use in that patient population. So you can have the surgery and get back to your normal activity a lot faster so you don't have quite as much downtime. Not that there's a huge difference, there's a slight difference, but also it's just a lot easier to use. And I like to say I probably put more ambIcord devices in men in the state of Georgia than almost anybody. I love the device, so absolutely not. Sorry for the long answer. That's a passion of mine.
That's a great answer. So I'm going to shift topics on you here for a minute. We have a couple questions surrounding testosterone. So I think this one will kind of sum them all up, but can you share more details on the 15-week shot or dose of testosterone versus typical weekly injections?
Sure. Okay. Just to correct, it's a 10-week shot. So the shot lasts 10 weeks. It's something called Aveed, A-V-E-E-D, Aveed. And basically the reason I like it and a fan is because, again, not too many people like to do a shot every week or every 2 weeks, especially a testosterone shot, because if you've ever done, it's thick and it has to be in the muscle and it's not the most pleasant thing that you can experience. This injection tends to be a little bit more friendly, patient friendly. And also the levels stay a little more stable. So that every week, every 2 week shot, there's a little bit of a fluctuation, what I call a roller coaster ride. You can shorten shots. Instead of doing every 2 weeks, you can do them every week. So half the dose every week, but then you're doing a shot twice as often. So big fan of Aveed. Again, we do a lot of that here at Georgia Urology. And again, Aveed is the name of it, and it works just as well, but it basically keeps a standard steady state level. And again, about every 10 weeks, you're getting the dose and you don't notice the dropping off near as much.
Okay, thank you. Is there a correlation or relationship between ED and BPH?
Yes, there is. It's about 30%. So 30% of men who have BPH also have ED. Actually, that number is probably a little bit higher. I should say it this way. About 30% of men who treat BPH will have improvement of their ED. About 30% of men who treat their ED will have improvement in their BPH. So prevalence is a lot higher than 30%. It's just the improvement rate. I misspoke there. So if you treat one, it's going to go, you're going to get improvement in both, but absolutely they're related. And those of us who do a lot of this, we're going to talk to you about your BPH. We're going to look at your PSA. We're going to talk about your testosterone, make sure that's normal. So it's that general men's health screening that we like to focus on. So we kind of look at everything. And a lot of guys will come to us with just, let's say, ED. And we ask a couple of questions and they realize they have more BPH symptoms than they probably realize. And we're going to focus in on that because we want to deal with that before we end up with a surgery for their erection, so that we got that all fixed and tidied up before we end up with a more procedure for their implants. We want that to be the last one we do. So.
Okay, and the next question, do radioactive seeds affect ED? I've had 68 seeds plus radiation.
Absolutely. The modality of how you choose the radiation, whether it's outside radiation, seeds come in low dose or high dose, are all going to affect the erection. So radiation, as we saw, has the same erectile dysfunction rate as the surgery for prostate cancer. So again, absolutely, though, it's treatable, it's fixable by the methods that we talked about. If you are that patient, I would highly recommend getting the vacuum erection device. Again, as I said, battery operated medical grade. We have some of them in the office, but you can get them off the internet. Battery operated medical grade. Use that device to stretch. And again, men who use that device before they either do treatment for, let's say, injections or especially a penile implant, they'll have a better outcome ultimately with it. So, but easily fixable by the same modalities, and you don't have to do without intimacy with seeds. Okay.
And then can you over pump the implant, the penile implant?
You really can't. Those of us who do a lot of them, I tell my patients, I want you to try to break the device. And I know that sounds really odd, but the point is, especially in that 3-piece device, you need to be inflating it beginning somewhere between 1 to 2 weeks, because what's going to happen around the device, you're going to form a little bit of scar tissue, and we want that scar tissue to be nice and pliable. And we also don't want that scar tissue over time to affect how the device expands, both in girth and length. So I will teach my men to, again, and I give them plenty of pain medicine to get through this, to almost overinflate the device. Now, I will say there are some couples, especially older couples, where they will choose how much they inflate the device. In other words, women can have some dryness and some atrophy and some discomfort, and they may not like the device at 100%. And that's a nice thing about it, is you really can kind of select what is enjoyable for everybody.
Okay, and just a reminder to everyone, I see some people are raising their hands. If you just want to type your question in the chat box, we'll try our best to get to those. And then the next question for you, Dr. Sharpe, it says, what type of anesthesia is used for these procedures? So I'm assuming the penile implant and the AUS and sling.
Well, for all of them, we typically use general anesthesia. However, you can do them under spinal. On occasions, with certain patients who have significant health issues, you can do these under a little bit of a local, especially I talked about the malleable device. Those can be put under something less than a spinal that allows intimacy to return. But as a general rule, general anesthesia is what I prefer. I find people do better with that than the spinal, but have done them both ways. So again, and as with anyone, we talked about the correlation with heart disease, you're going to be seeing somebody, so we're going to be evaluating for that. So a lot of people, and not so much now, but if I look back at my career 15 years ago, in the beginning when I started doing, a lot of people had the reservations, do I really want to have the risk of a surgery to return sexual intimacy with my partner? The risk of the actual surgery with anesthesia is minimal. These are no different than if you had a hernia repair. So again, if you were 65 with diabetes or 85 with, whatever, and you had a hernia repair, if you could have that procedure for that reason, you could have it for these penile implants.
Okay, and the next one is, how do you treat pain after implant surgery?
I probably give more pain medicine for penile implants than anything. That's not to mean it's painful. It is uncomfortable. Some people on this call don't like when I say this, but people will say they don't like me for 2 weeks and they want to buy me dinner at 6. The point is, it is uncomfortable in the beginning, but every single patient that I've ever taken care of that I can think of has said it's worth it. In fact, actually, with most of my patients, as you can see, I'm not the most formal urologist on these webinars. I wanted to make this very interactive. But what I will say is they come back and they say 6 months later, it wasn't that bad. And I look at them and say, wait a minute, are you the same guy that threatened me 2 days after the surgery? Now, again, it's not that bad. Simple hydrocodone, maybe some Percocet will control the pain. It would be no different than a knee or a hip. It's just a lot of people get concerned about it for the first few days because where it is. In other words, to draw an analogy, in pediatric urology, parents get really nervous about us doing circumcisions on their children. And we'll tell them a lot of times, hey, your kid would be a lot more upset if we operated on his thumb than to do the circumcision. Same thing with us as adults. We think of this area a little bit different. So mentally, it's a little bit more uncomfortable. But again, there are plenty of pain medications to control that. And we don't let people with this go through them with a lot of pain and discomfort. And again, to say 96% of people that do it would do it again. So therein lies the answer. The pain is tolerable, not bad enough to warrant not having the procedure.
Sounds good. And now I'm going to flip back to testosterone. Is Avede testosterone treatment affordable?
Usually Avede is covered through the insurance. Now we do have an approval process that we get and make sure, but it's a lot more acceptable now than it was just even 3 to 5 years ago. So in fact, actually, it's funny we're talking about this. Today, my MA and I were talking, we've had 3 approved within 48 hours, and it used to take about 2 to 3 weeks. So a lot more acceptable and usually covered through insurance, and we check on that. Now, it's not going to be as cheap as your injections every 1 to 2 weeks. And my analogy for that is organic apples are not the same price of regular apples. And some people choose to have an organic apple as opposed to a regular apple. So my point of that is there may be some mild cost, but you have to weigh that against having to do a shot every 2 weeks and the discomfort of that, or even every week, as something that's a lot more convenient than just simply doing it every 10 weeks. And I also don't have to worry about it as a urologist, you're taking your drug. So when we look at labs, when I do a shot in the last 10 weeks, I know whether you're taking that medicine and whether we're being effective at treating your condition.
Okay, and I just want to also address one thing really quick. I have a couple messages of people that came in a little late. This is recorded, so this recording will be sent out after for everyone. So if you missed some of this, we'll be sending this out. And then Dr. Sharpe, I'm going to switch back to the penile implant questions about that. This person has diabetes and high blood pressure. So could he have an ED implant and sling at the same time?
Again, the answer to that is yes, you'd want to do them at the same time if that's the cause of the leakage. Now, again, remember we talked about 2 different types of leakage. So we would iron that out in clinic to decide if the sling is really what you need for the incontinence. But I would say over the past 5 to 7 years, I've probably done more penile implants on people who have diabetes as their primary etiology or cause of their erectile dysfunction than I have prostate cancer or other conditions. So diabetes is an extremely common cause, because remember, we looked at the 85% of ED was vascular, medications, and drawing a blank here, Kelly, help me out. But anyway, 85% are those conditions that are not related to prostate cancer. So again, diabetics are on have vascular issues, have medications, and comorbid disease. That's the other one. So
yep, you got it. And I know I said at the beginning of this program that we're going to go for an hour. Dr. Sharpe, there are a lot more questions. Do you mind staying on for a little bit longer to answer?
We can go a little longer. I want people to get their questions answered.
Perfect. So this person says, how do I discuss this with my current urologist?
Again, I would say two things to that. Number one, my hope is in urology that you wouldn't have to bring it up, that it would be brought up as a general screening test. But if he does not, I would simply just ask him, as I have erectile dysfunction, and what are some of the options? I will say that, again, I think the numbers, if I check correct, about 5% of urologists in the country do more than 20 to 30 implants a year. And maybe with the exception of 1 or 2 years over the past decade, I've been in that group. So you do want to get to someone who does a lot of them, because outcomes are affected by the frequency of doing the procedure. And just because you do that doesn't mean you have to give up your current urologist. There's nothing wrong with seeing a specialist for this type of procedure and then going back and maintaining care with him. But again, I would say always, if you got a urologist, just talk to them and see what their opinions are. I will give one disclaimer is, again, there are a significant amount of urologists who don't do these, and they have a little bit of a skewed opinion, again, because they don't do it. They don't see the benefits. That's a common thing that I personally saw in the beginning of my career with, let's say, primary care doctors. When it came to a new area, they said, look, we had somebody and they did a few here and there, and they didn't have great outcomes, or patients had problems, and I had to take and retrain that. Those of us who do this frequently tend to be efficient. We tend to make sure that we're there for our patients so that you ultimately end with an outcome. And again, Kelly will know I've said this many times with patients who come to me for second opinions or who've had a device that didn't work. At the end of the day, you have to have a functioning device, and we will guarantee at Georgia Urology at the end, guarantee as much as we can. Nobody's perfect. But again, that we end up with a device that is functional at the end. So that's how I would just approach it. And finally, I would just simply say that the doctor that doesn't like a second opinion is not the doctor you want. So again, this is your healthcare and your condition. Your primary goal should be to you and your spouse, not the feelings of another individual. Take care of your health care and let the chips fall where they fall. And again, not a popular response, but it's truthful.
Great. And then the next one I'm going to ask, do you have to wear a catheter following the procedures?
You don't have to. I tend to leave the catheter overnight. And the reason is because I have found over my career that by leaving the device partially inflated does several things. Number one, it helps a little bit with the bleeding and the swelling. Number two, and this is reality, it makes the pain a little bit better, because all the discomfort right after surgery, when you're able to look and know, hey, this device will work and I'm going to go through this pain, but it's going to work. It's not going to be like taking a Viagra and it didn't work and everybody's disappointed. So that's a two, and it's really hard to pee with the penis erect. So I leave it overnight about 70-75% erect, and then leave the catheter overnight, and then we take it out. But again, there are situations where I don't do that. So it's not a have to, it's more of just what I have found to be the best scenario.
Okay, and then I'm gonna switch back over to low T really quick. The question is, who does the 10-week shot? The physician or the patient?
No, the physician. It does have to be done in the office, because you do have to be monitored for about 10 to 15 minutes after the shot. So it is done in the office. But again, typically, those of in Georgia Urology, we have a lot of people using this drug. So we try to make those visits very efficient as we can. It is not something you can do at home.
Okay. And then going back to, I want to make sure I read this question correctly. The question is, how well does it work with incontinence, the implant, and also can you ejaculate with the implants? So I'm assuming we're talking about the penile implant. So can you ejaculate with the penile implant, and does it affect incontinence?
So first of all, the implant would not affect your continence. In other words, if you're dry and you have a penile implant, it would not affect your ability to be dry. If you are not dry, putting a penile implant would not help you be dry. So that's the first thing. The second thing, as far as ejaculation, that is normal. So again, that's what people, as I said in the earlier talk, they just say it's reliable and it just works. These devices, whether they're the artificial sphincter, or the penile implant or the sling, they just work. They get the objective in the penile implant from an erection, and it's satisfactory. Now, if you have prostate cancer surgery, whether that's radiation or surgery, or prostate cancer and you've had radiation or surgery, the ejaculate is typically dry anyway. So it's what we call a dry orgasm. But if you have a normal ejaculate, just because you have heart disease, the pleasure, the sensation, the ejaculation should not be changed by the device.
Okay, and then this fits well with the next question. This person has retrograde ejaculation. Is this from surgery, and is this unhealthy?
The easy one is not unhealthy. There are no ill ramifications from retrograde ejaculation. Typically, retrograde ejaculation occurs from prostate cancer surgery, usually a TURP, a trimming of the prostate. It can occur in diabetics or people with, spinal cord injuries or those kind of things. So, again, it's not something that we typically fix. We reassure couples and say, look, there's no ill effects and it doesn't have to come that way. And I mentioned there and had a thought, the spinal cord, we talked about these working in neurological conditions, whether they're incontinence or penile implants. So spinal cord is a common injury that we see these days, and people have some ED. And I'll just say that, again, some of those patients are pretty young. So a common question is, how long do these devices work, penile implants, et cetera? And I'll just let you know that the longest device I've ever had work is 27 years. It currently is working 27 years later. That is a type 1 diabetic, had it put in his 20s, and it is still working on a frequent basis. So these have very good longevity with them. So.
You just answered my next question, which was how long do implants last? So great. Yeah. And then the next question is, how do you get fluid and keep fluid into the implant?
So the implant itself is a closed system. So there is no leaking out of the system. And if on rare situations, the device, whether it's the balloon or the reservoir or the pump, would fail or rupture, the fluid that's in it is saline. So if you went to the ER, the first thing they would do is start an IV and give you saline. So there's no ill effects of the fluid leaking out, which is a very uncommon scenario. So I don't want people to worry about that. But again, if in a situation where, let's say you put the device in and 10, 15 years, whatever years later, the device doesn't work, fluid may have leaked out through the connections of the device or other reasons. And that's a simple fix where you simply just take the device out and put it back in. No different than, let's say, like a knee replacement. I think they talk about knees and hips, talking about maybe 10, 12 years longevity. We've just said here that we have these working as much as 25 years later. So.
Okay, and then I'm going to merge two questions. So what is the possibility of penile implant damage due to serious cycling? And then also someone had asked, would bowling or playing tennis affect the penile implant?
No. The point of these devices is to return normal activity, whether that's sexual intimacy or continence. So playing tennis and bowling are the easy ones. Absolutely not. And again, I promise you, no one at that bowling alley will know it's there, or even tennis shorts if you want to wear the old style. That device, no one will know it's there. That's the first thing. Now with riding bikes, again, some people where the device sits in their scrotum may kind of feel the device. I tend to recommend what's called a saddle seat if you're biking anyway. Cyclists have a higher incidence of erectile dysfunction, and it's injury to the artery, which can also be affected by how you treat it. So that saddle seat is better in that situation. It also, in the penile implant, because of the way the seat is shaped, you're not sitting at the scrotum. That part for the man is not there, so you don't typically affect that. So again, auto inflation while you're cycling is not going to occur, and most people would not know it's there. And I have plenty of cyclists who have a penile implant. Now, I do not recommend you going cycling a week after we put the implant in. So realize if you do cycle a lot, you may give that up temporarily.
Okay, then this next question is, how effective is the Gainswave method?
So Gainswave, for those who don't know, is basically a form of penile sound waves. Okay, number one, just a disclaimer so you know exactly what Gainswave is. Not a urological company. It is not a treatment company. It is solely a marketing company. Okay. So again, people know it is Gainswave, but the devices are different. The people that doing it typically are not urologists. But on average, 50 to 60% of people who do penile sound waves, whether that's by the marketed name Gainswave or other devices, are going to get some improvement. That is a little bit of a pet peeve of ours here is, again, the ads that you hear is they quote, they fix everybody, or upwards of 85 to 90%. We looked at our patients after the first year at Georgia Urology. That is an unattainable expectation and not clear marketing. So again, it is effective. It does work. The problem is you don't know who it's going to work in. Efficacy rates, 1 to 2 years is all you're looking at. So you don't have real long-term rate. Some people do need to kind of get retreatment, and that's fine. If you're taking, let's say, a Viagra and you do penile sound waves, and now you're not having to take Viagra in a year or two, you have to get a couple of treatments. And a lot of people don't mind that, and that's fine. But again, I think to be reasonable and honest, you have about a 50 to 60% improvement in erectile function. You also have to classify one last thing is what is increase or improvement. So an increase or improvement is, I was, let's say, taking 100 milligrams of Viagra. Now I'm only having to take 40 milligrams. That's counted as an improvement. Okay. Or I was on injections and now I'm able to get by with pills. That's an improvement, but the patient still has the condition that they have to treat.
Okay, Dr. Sharpe, I think we're going to do 2 more questions, and then we'll wrap this evening up. And for those of you that did not get your questions answered, I do have them and have your contact information so I can circle back with you. But the next question is, what is your take on Resume for BPH?
Absolutely, and I'm starting to mention that early. So Resume is a treatment modality for BPH, or what people call enlarged prostate, where the prostate wraps around the urethra, gives typical symptoms of slow stream straining, pushing. Resume injects steam at a temperature which causes the cells to die and the body reabsorbs it. Honestly, I'm a big fan of Resume. I like it. I think it's a great treatment. I did one today. It's quick, it's easy, it's done in the office. You don't have to go to the operating room. The one thing I tell my patients is, with Resume, as opposed to some of the other modalities, you have to understand that the first few days or a week or so, you have a little bit more time to recover. In other words, Resume through the steam is causing an inflammatory response. And because you get an inflammatory response, you're going to get a little bit of swelling, and you don't get quite as an instantaneous relief of your symptoms. But also Resume has a little bit less of a retreatment rate. So everything in life is a trade-off, okay? So some of the other modalities may give a little quicker response, but they don't last as long, whereas Resume, you may have a catheter for an extra couple of days. You may have a little bit worsening of the frequency and urgency, but ultimately, at the end of the day, your retreatment rates of the BPH are going to be less. And you also don't have an actual device left behind or scar tissue that can occur from actually physically removing. There's not a superiority study. So Resume is not better than UroLift. UroLift is not better than Resume. Same thing with TURP. So each patient has to look at, I'll tell you 3 things: size, shape, and pressure. What's the size of your prostate? What's the shape, and where is it causing the obstruction? And number 3, what pressure is your bladder having to do to get it out? So that's kind of how I look at BPH and the different modalities out there. So.
Great, and then we will wrap it up with this last question. This person asked, why is it not as hard as it was when I was 35? I'm now 53. And then he also says it will get hard, and then as soon as I change position, it drops off. Why?
So again, remember we talked about the slide. This is a blood flow issue. So as the blood flows into the penis, that artery is responsible for that. So if the artery is, for lack of a better term, clogged, constriction, doesn't function as well as far as the muscular, you're going to affect the rigidity. Typically, when you look at men with ED, they're going to notice a little bit of decrease in rigidity. Maybe those nighttime erections may go away. You may lose it in the mental of intimacy, especially like changing the position. So it's kind of the first things that we see. But again, that's where we're really going to encourage those men to look at their lifestyle, number 1. Number 2, absolutely start to see their primary care cardiologist, because again, we talked about it as a screening, and that's the most common thing. There was a study that looked at 50-year-old men who said, essentially, I am as healthy as a Georgia football player, and I am fine. No offense to all the Roll Tide people out there. But that being said, I'm a college athlete and I'm healthy and I can do anything I want to, but I have some mild ED. 40% of those men had cardiovascular disease requiring an intervention at a cardiac cath. So again, let's put that in terms. 40% of those men had blockage of the heart enough that they needed some intervention to prevent a massive or significant heart attack. So again, if you're that man out there, please get a calcium score, see your primary care, get a stress test, not a basic EKG, because it is a predictor of things going on. And again, using a vacuum device to kind of stretch will help expand that artery that uses the tissue that expands. So all those things to do, but it's a blood flow issue. And I think that's where you need to be evaluated to make sure it doesn't represent something somewhere else.
Great. Thank you so much for your time this evening, Dr. Sharpe. And thank you to all of you that logged in. I hope you got a lot of answers to your questions and a lot of great information on your health. Dr. Sharpe, anything you want to say to close us out?
Yeah, no, again, just congratulations for coming and actually seeing, getting some information, because a lot of people suffer in silence. Again, my numbers are here. We're happy to help men who want to restore this condition back to some sense of normalcy. So,
great. Thanks so much. And y'all have a good evening.
Awesome.